We have Dr. JYOTI MATALIA from Narayan Netralaya, and she's going to talk about ocular myasthenia gravis.
Good morning all. I'd like to thank Dr. Rashmin for this opportunity. I'm going to be talking on ocular myasthenia gravis, diagnosis and management, and I'll take you through the pathophysiology, the diagnostic tests, the management. So let's begin. We all are aware that myasthenia gravis is an autoimmune condition which affects the neuromuscular junction. It primarily affects the orbicularis oculi, the levator, and the extraocular muscles in both the eyes. The pathophysiology, coming to that, as you say, we know that at the neuromuscular junction, the acetylcholine that is released binds to the receptors. But in myasthenia, you have basically receptor antibodies which destroy these receptors, resulting in accumulation of acetylcholine and no generation of the AP at that junction, and hence the myasthenia develops. So what are the other important aspects? We have to know that these two proteins, the MuSK and the LRP4, are important in the construction of the receptors, and these are absent in cases of myasthenia. So let's look at how do you really detect these. So it's basically a clinical diagnosis, very, very important. Clinically, you need to find them out, and I'll take you through these 5 other aspects. So coming to it, clinical features, classically variability, very, very important. Ask in the diurnal how much it does make a difference throughout the day. Usually they'll tell you in the morning the patient is much better and worsens. It's associated with ptosis, which could be asymmetrical, could be unilateral or bilateral. Diplopia, because if the extraocular muscles are involved, there'll be difference of squint in different positions of gaze, and so diplopia. The pupils are, however, very normal, and that is very, very important for us to differentiate between that and cranial nerve palsies. Classically, the fatigue test. These are the tests that you do in a clinic. When you make the patient look in sustained up gaze, you'll see that the ptosis worsens. That's one. And then classically, the Cogan's lid twitch test. In saccadic check from down gaze to up gaze, you'll know that the upper lid suddenly overshoots. And this is the classical test to tell you that this patient could be having myasthenia. Then coming to the pharmacological tests that we do. First, before that, eyes test, very important. Do it in your clinic. You need to put the eyes over your lid for 2 minutes. Ensure intermittently that you can release, but check that the ice is actually touching your lid or not. Many a times it just touches the brow and then you really don't get the test properly. Very, very simple and effective test. The other is a sleep test, which after 30 minutes can see a resolution of ptosis or even ocular motility. Many a times that you're dilating the patient, you can tell him to close his eyes and rest and check him immediately post 30 minutes. That's one thing which you can do. And the other important thing is especially a history. In the morning when the patient gets up or after an afternoon nap, ask him how is his eyes. Does he feel much better? And that's one way to detect the sleep test which they do at home. Then the other edrophonium test, but now not available. So neostigmine is a long-acting anticholinesterase which you can do, and after 30 minutes you see a resolution of ptosis and even an improvement in ocular motility. Remember, the sensitivity is more for generalized myasthenia and about 86% for ocular myasthenia gravis. Coming to the serology, commonest acetylcholine receptor antibodies, more specific, helps confirm the diagnosis if positive, but normal titers does not exclude the disease, and in ocular myasthenia only 50% is the positivity. The other is a MuSK antibodies, positive in about 40 to 50% of generalized cases, but only 5% of ocular myasthenia with negative acetylcholine receptor antibodies. Third is LRP4 antibodies, positive in about 20% of OMG cases, who are negative for the other two antibodies. But interestingly, 10% of OMG cases can be triple negative, that is negative for all these, that we have to keep in mind. Then coming to electrophysiology, we find that single fiber electromyography is very sensitive, about 85 to 100% for OMG and 91 to 100% for generalized cases. Repetitive nerve stimulation study showing a decremental response in about 33% of poor ocular myasthenia. Now coming to the other tests, yes, CT's test to detect the thymic hyperplasia and the thymomas. Thyroid function test because there could be a concurrent autoimmune thyroid disease associated. So now that we have got it, let's go to the management aspect of this. So the principles are 2 ways. Either you increase the acetylcholine availability or you prevent the acetylcholine receptor binding with the antibodies. And how can you do? We can do it pharmacologically. So these are the 3 treatment options that you have. First is pyridostigmine or mestinon. It's a prototype drug which inhibits, causing prolongation of the action of acetylcholine at the neuromuscular junction. No effect on the natural history of the disease, and only 20 to 40% of ocular cases exhibit a good favorable response. Then comes corticosteroid, which is the second line of treatment, along with pyridostigmine. It is up to 80% good in OMG, exhibiting good response, and can be combined around with pyridostigmine. And there's an epitome study in which they have shown that by gradually increasing 5 milligram, they have found that there is a good response in those in which prednisolone was given against those who did not get. And they found about 15 milligram per kg was the best dose they got to get the best results. So let's look at this particular case. That we had a child who presented with bilateral ptosis, left eye more than right eye, with extraocular motility showing limitation of elevation and adduction in the right eye, depression by -3, and abduction was full, like a third nerve partial in the right eye, and left eye complete ophthalmoparesis. Pupils were normal. So you have something like this. Remember, when it doesn't fit into anything, and an MRI was normal for this particular patient, you have to see for myasthenia. And what we did is we asked the father that the morning she gets up, send us a photograph. And when we looked at the photograph, she was perfectly normal, indicating that this was actually a myasthenia. So she underwent treatment with pyridostigmine, that is mestinon, and corticosteroids, and did pretty well. You can see after first week, right eye is completely resolved, left eye is still having limitations. But after 3 weeks, there was a complete resolution, and after about 6 weeks, she is absolutely normal. The other aspect is immunotherapeutic agents. These are reserved for patients when corticosteroid risk exceeds the benefit and reduce the risk of OMG to GMG and changes the natural course of the disease. They have shown that 12% of cases of ocular myasthenia on immunosuppressives develops generalized, as against 64% who are on immunosuppressants either due to the late referral or uncertain diagnosis. So these include basically azathioprine, which is good for even ocular cases. You have mycophenolate mofetil, which is effective in ocular cases. Then IVIG and plasmapheresis left for those which are refractive. And finally, rituximab is more so for generalized cases. So surgical options are basically reserved, like thymectomy is beneficial in patients during the early course of the disease with significant follicular hyperplasia of the thymus gland. In non-thymomatous OMG, complete remission has been achieved in 50% following thymectomy and improved symptoms in additional 20%. Thymectomy can be considered in those which are which acetylcholine receptor antibody seropositive cases who have become unresponsive to medical therapy. So what is the basic algorithm then for ocular myasthenia gravis? Yes. Clinical examination, as I said, it's a diagnosis of is a clinical diagnosis. Eyes and sleep test, fatigue test. Look for any generalized signs. Rule out alternative neurological pathology. If after that you still clinically suspect ocular myasthenia gravis, do your acetylcholine receptor antibodies, the MuSK antibodies, and the LRP4 antibodies. If it's seronegative, you can do electrodiagnostic testing as mentioned here. If consistent or if seropositive, then you know this is a diagnosis of OMG. But yes, if you find all this negative, you need to do an MRI, which is also important in all cases, to rule out the actual cause, consider empirical therapeutic trial, and repeat antibody testing in about 6 to 12 months, which if positive will confirm the diagnosis. Hence, to summarize, if you have myasthenia is always a clinical diagnosis. It's a great mimicker, so you have to look at any patient who has got ptosis and with any ptosis or diplopia and absolutely normal pupils. That's important. Give importance to the history of variability and fatigability again and again. Don't forget that. Don't get biased by diagnosis anywhere else, and always coordinate with your neurologist to rule out a generalized case of myasthenia. Thank you.
Thank you, Dr. Jyoti. Comments from panel's experts, Chair?
Let me say one thing. I think we are a tropical country, so it gets worse during summer months. So one thing we should keep in mind. Another thing is diabetic population also is more prone for myasthenia. So with thyroid, we should also look for diabetes mellitus, because that is also autoimmune at times. So these two conditions are important and very common in our setting.
Ambika.
What is the protocol you follow for a myasthenia patient if you plan for a cataract surgery? Do you escalate the medications or do you get a clearance? This is a simple question which I wanted to rule
I
out.
would get a clearance from our neurologist before doing it.
Yeah, because many a times, one or two times we have seen a myasthenic crisis
Okay.
post-cataract surgery. So you have to be primed for that also. If at all you're going to plan for any surgical procedure to a myasthenia
Especially
patient.
with anesthetic agents.
Anesthetic agents,
So we usually,
preferably.
Absolutely.
and we have it under MAC, that is like a monitored anesthetic care at the same time.
And can I check whether if it is a pediatric myasthenia, Because most of the times in the pubertal age, around 12 to 14, there'll be a physiological thymic hyperplasia.
Okay.
How do you differentiate that versus a thymus lesion? And would you advise for a thymectomy in such patients?
Okay,
When they are not
when
advising?
it comes to management of this, I usually
Yeah.
coordinate with our pediatric neurologist. So my advantages being in a health city, I have a direct correlation. So when it comes to managing, we both would decide. I'd get her opinion before we decide anything additional has to be done. So in case of taking decisions about medications, it's primarily that I refer to her, and then together we monitor. So I will take the ophthalmic part of it, and she'll be handling the treatment
Any
part of it.
pediatricians are less happy about thymectomies at that young age, and they generally would recommend unless it's only if it's a refractory myasthenia. They do not recommend. They're not. I mean, obviously because we want the entire natural immunity to develop. So unless it's like really significantly large hypertrophied or it's refractory, they tend not to. Of course, you need to always consult them. You obviously would not be the person who's be deciding, but in our experience, I've seen that pediatricians have been less than encouraging. Yeah.
Only
And
challenge
thymectomy
is
may not
that,
always
Yes,
help,
please,
that is
please.
another problem.
only challenge is that if the malignancy causing this, the biopsies could be given important things. Recently, we have seen one case with multiple lymph nodes, sublymphatic with a thymus enlargement, with ptosis. So ultimately, probably in some atypical cases, you require a biopsy to prove these cases.
Yeah.
There are-
Malignancies can cause myasthenia, like Eaton-Lambert syndrome. That is another group of conditions, though of course they are slightly different. They are pre-synaptic, but they can also cause, and that's again you need to investigate and keep that in mind that the person could be having any kind of malignancy or any other disease. So a lot of masquerades there.
Yes, Manju.
That's very important.
Yeah, and just with the myasthenic crisis, I would also tell the patients that certain drugs need to be avoided, like beta blocker. So we don't want to precipitate myasthenic crisis. Your neurologist may or may not convey that, but that's an additional thing that I would say.
Yeah, right.
And two of the important clinical signs that I would recommend is, one is look at orbicularized ocular tone. That's one of the important signs which tells you that this can be myasthenia. And one sign which Dr. Arjun Das keeps referring to, early sign of a generalized myasthenia is that you will be able to push the patient's scalp because the neck muscle would go, their power will go down, so you'll be able to push the patient back just with one finger. So these are two clinical signs which you should look at, somebody who you suspect myasthenia.
Yes, one point which I have found consistently positive in some patients is smoking aggravates myasthenia or precipitates. So I've seen that in many patients. If anyone has had that experience, and stopping smoking definitely helps in.
Yes, I agree.
Probably
Yeah.
heat is an important marker, I think. Maybe smoke has, it's hot, so maybe it's,
Yeah,
yeah,
Most of the neurological conditions smoking
can
is
be.
worse.
smoking makes it worse.
I just wanted to add that most of the
And
pediatric
thymectomy
myasthenias
may not
are-
always help, so I mean the results are not always, they may not always relate to thymectomy, so that's a very controversial area, indications and all those things. So I think we should not get into that area.
Yes, Dr. Virender?
Yeah, most of the pediatric cases have a self-limited course, so they may not require prolonged dose of immunosuppression also. They do very well with the initial immunosuppression with steroid, followed by being on pyridostigmine for a fair amount of time. They don't have so much recurrences as compared to adults and younger adults who will usually have much more recurrences, relapses will happen. So
Pediatric also has neonatal and congenital, all those issues, so it's a very vast area again. And most of these are ocular myasthenia, so they are going to be okay with time.